Welcome to The Cut, a series where I'm talking to experts about how small changes can have a big impact on patient outcomes after surgery. Hello, Sebastian. Thank you for joining me today. I'm really glad that you could spend some time and have a chat with me on this series, The Cut. And I'm really keen to get your perception or your understanding of why it's so important to educate the patient when it comes to surgical wound management. They're off home. Just tell me how important it is.
As you said, it's important, first of all, we have to start early. We have to start before the patient has the surgery, so that they can have the instructions. They get to know the signs of an infection, for example, especially when they have different skin tones. It's not always the same, like it's written in the literature. Now the literature is more and more diverse and is described with different skin tones, but also that they have time to ask questions. Asking questions, I didn't understand that, because we know you give me some information about the surgery, I can probably 10%, 20% I can remember, the rest not. And then one other thing that I think it's important, that is very nicely also described in the literature, my research is more in venous leg ulcers, but how you present information. Do you give the patient a leaflet written in their own language and go through the leaflet? It shows that patients are more informed afterwards, especially if they know if they have a comorbidity. I have a diabetes. What kind of impact does it have if my blood sugar is outrageous all in a sun? So that is, I think this is one part that is important. And when we go to the healthcare professionals, we know who is taking care of the patients. We saw that now during the pandemic, we had a shift also from the patients. We had a shift from inpatient to outpatient to the home care. And we need our physicians and especially nurses, that they are very well educated, that they have the tools to educate patients.
That's so very true. Education really is that secret. It's that magic bullet, in a way.
Yeah.
Would you agree?
I agree. And when we talk about education, it's, I can educate you. Do I educate you via Zoom? Do I educate you in person, like here? And especially when we sit next to our patients, it's the verbal and especially the non-verbal communication.
Of course.
This, I think, Derek can say, how do you feel? Did you understand? Or
no.
So then there we have to have the feeling. And another problem I see is time. Time, because it's not between two appointments or, oh no, in 2 minutes I have the next patient. So it's really, we have to take time. And we see that also in the literature. If a nurse takes time, I say 10 minutes, and this shows my recent randomized control trial, 10 minutes sitting with the patient, we can improve patient outcomes.
It's all about time and connecting with that patient, with that individual, and understanding their needs, isn't it?
Exactly.
Because it goes beyond just the wound. It's about everything else that's happening in their lives sometimes.
Exactly. It's their entire social environment. Who is involved? One example is from my research shows that when I take time with the patient and the family, we had something about education with venous leg ulcers and nutrition. We involved the wife of this patient because he said, I don't cook, it's my wife. And so she could change something, and
Yeah.
this is what we want. So that especially more and more patients are treated at home, or they're taking care of their wound at home. That's why it's important.
And having that knowledge and expertise coming from their attending physician or wound care specialist is so important. Do you find that even though you sit and you're consulting with the patient, there are other things that you can use, such as digital platforms, to keep that education and that connection together? And how does it work in your clinical practice?
So we were thinking, it was funny, we were thinking giving something electronically.
Yeah.
But our population with venous leg ulcers, it's around 70.
Yeah.
So they like to have something in their hands, some paper. And we developed a brochure. And this can be done for surgical site infection.
Absolutely.
With easy, with images, with descriptions, and so they can write in there. They use that as a tool. And what we ask our patients, and it's also described in the literature, we give them homework.
Yeah.
Now we have chapter 1, we discussed pathophysiology, and then chapter 2 is prevention, etc. And we ask them, did you have any questions? We give them a feedback, we give them a summary, and we point out especially the key messages. Yeah. And every time, so it's like one drop after the other, and then we have the glass full of water, for example.
That's great.
Yeah.
Because you're just imparting knowledge to them that's relevant, but it's timely.
It's timely, yes.
Because we all learn in different ways, don't we? And when we're trying to educate patients, what may work for one patient
doesn't work for the other.
Exactly.
Exactly.
So it's understanding that.
And one thing, especially in Europe, is the language barrier.
Yeah,
now with all the refugees
yes.
that we have here. In Switzerland, we have 4 languages. If you speak 3, it's good. But for example, in Geneva, everything is in French. If you come from the German part of Switzerland and you don't understand French, so this language barrier, it's also a problem. And therefore, it should be good if we have some translations, or if we have somebody that could help with the translations.
Of course, because that can be a really big barrier to try and impart knowledge.
Yes, yes, yes.
Big challenges.
Yes.
What other challenges do you see in the future when you're looking at clinical management of surgical wounds? So say, for example, surgical site infection. What do you think are some of the big things that may shape the future for us?
Big things. First of all, one big thing for me is we have to change the system. We treat and we do not prevent. We have to turn this around.
Flip it.
First, we have to prevent. So if we can prevent, then we can manage, and then we can treat. Yeah. So first of all, we have to flip this. Then we know there are so many dressings. It's like a jungle.
It's like a lolly shop.
Yeah, that's very nice.
Candy shop.
A candy shop. There are new dressings coming out with captors, with wound pH, etc.
Exactly.
So it has to be easy to applicable for patients because they're in the hospital and go home afterwards.
That's right.
We have to have good education material in different languages, and we have to have enough staff that have the education to educate patients. And we don't know if there is another pandemic, and what will be. It's the shortage of staff.
Yeah.
For example, here in Paris, they closed 30% of the beds because of lack of staff. And so that means it's a shortage of staff. It is shortage of beds. So patients are treated mostly at home.
Yeah. And it's a breakdown in the system. You're absolutely right. It's a system failure in a way. and it's all the multiple moving parts within that system.
Exactly.
One doesn't work, then there's that follow-on effect.
Exactly.
It's Swiss cheese theory. There you go.
Exactly.
Sebastian, it's been an absolute joy to talk to you today, and thank you so much for sharing your
very
story
welcome.
and your experience, and we look forward to seeing you in the next episode of The Cut.
Yes.
Thank you.
Thank you.